Hello everyone, this is Dr. Helge Alexi and I welcome you to another clinical case I today want to show you. It's about a patient who suffers from a complication of a procedure he got some time ago. Well, let's get right to it. I called this clinical case "Why is this patient coughing?" and this is part 1. Part 2 will come in a couple of weeks. And the reason why I divided this case in 2 parts is that the patient had so many pathological findings in the transthoracic and transesophageal echo we performed that it would exceed the time of one video. But now to this first case. I want to start the case with a CT scan of the chest, and the CT scan is going from cranial to caudal, and I want you to have a very good look at it and afterwards tell me what pathological findings you have seen. So here it goes. Have a look at it and see what pathological findings you see. The patient is coughing. He has some medical history. Okay. So that would be possible answers and possible findings you could have seen here. A would be sternal cerclages. Did you see them? Or did you see any? Did the patient have pacemaker leads? Did he have a pulmonary embolism? Did you see signs of increased RV pressure? Or is it all of the above? I'll show you the CT scan again and then you can make your choice. A close look. Okay. So, what is your answer? Take your time to choose. A. Sternal cerclages, B. Pacemaker leads, C. Pulmonary embolism, D. Signs of increased RV pressure, or E. All of the above. Well, I'll give you the answer. It's E. It's all of the above. We can see all these things here, A, B, C, D, and I'll show you where to find them. If we go through here in the sternum, there we see some glooming structures here, and these are sternal cerclages. They make some glooming artifacts here. So sternal cerclages in the sternum. There you could see them. And look here, the vena cava superior. We already see here some pacemaker leads going from cranial to caudal down here. So cerclages, pacemaker leads. And now I want you to have a closer look at the pulmonary arteries in the left lower lobe. Here the pulmonary arteries are very good contrasted with the contrast the patient was given while the CT chest scan. And here you see that there is a clot in the left lower lobe pulmonary artery and going a little bit more down. And here are the pacemaker leads of the atrium and the ventricle going to the right apex. I'll show you in a couple of seconds. And have a closer look at the size of the RV ventricle. He's minimal the size of the left ventricle, maybe even bigger, and he performs the apex of the heart. The right ventricle is apex forming in this case. And this is the ventricular lead going to the apex of the right heart. Again, sternal cerclages here, the pacemaker leads going down the superior vena cava, the pulmonary embolism in the left lower lobe, the right RV pressure, and the ventricular lead to the apex. Okay, so that's from the CT scan. Let's come to the patient. It's a patient 50 years old, it's a male. He was admitted by the primary care physician because of persistent coughing for 4 weeks. The inflammation enzymes were high. CRP was 90. In our lab, it should be under 5 leukocytes, or 14,000 should be between 4 and 10, 4 and 12, depends on the lab, but it's slightly elevated. And the procalcitonin PCG is 14, and in our lab it should be under 0.5, and the body temperature is 38.8 degrees Celsius. The first chest x-ray the patient got in the emergency department was without explaining pathology, and this is why the patient got a chest CT scan I just showed you, with a diagnosis of a pulmonary embolism in the left lower lobe, what would be very good explaining his symptoms with coughing for the last few or 4 weeks. And afterwards, when he was on the ward, he got an echo performed. That's a standard procedure in our hospital to evaluate patients who showed up with a diagnosis of a pulmonary embolism, just to evaluate the heart function, the RV load, and so on. This patient had some more medical history, I have to tell you, and this all started with an aortic valve endocarditis in 1993, and afterwards the endocarditis destructed his aortic valve with a progredient aortic regurgitation, and this finally ends in a Ross operation in 1999. Just to refresh your memory, Ross operation is the following procedure. Ross operation procedure is an operation where a diseased aortic valve has to be replaced, and first the aortic valve is cut out and the coronary arteries are detached from the aortic valve, because we need them afterwards to be reattached on the graft of the valve. The pulmonary valve of the same patient is also cut out and put in the position of the aortic valve. So the pulmonary valve becomes the new aortic valve. Afterwards, the coronary arteries are reattached now on the pulmonary valve, that is the new aortic valve, and the place where the pulmonary valve had been is filled with a graft of another host with the originally pulmonary valve. So this is the result of the operation. The original pulmonary valve is switched to aortic valve position, and with another graft the pulmonary valve position is replaced. Postoperative, the patient suffered from a total IV block, IV block 3, with the need of CPR and consecutive implantation of a DDD pacemaker, with battery replacement 2009 and June 2016 at ERI, elective replacement indication. The CPR, because of the AV block, was very short and it was in hospital. It was shortly after the operation was performed and the patient was still on monitoring on the ICU, so the assistly was seen directly and the CPR could start immediately, so there were no neurological defects the patient suffered from when I saw him. And now the actual incident is the pulmonary embolism. Now let me show you the echo loops. Here you see a peritoneal long axis view. In this view you see a little bit atypical movement of the septum. The posterior wall is contracting very good. Overall the systolic movement of the left ventricle is okay. Here you see the aortic valve that is originally the pulmonary valve and replaced while the Ross operation. Here you see the mitral valve with a structure on the, or it seems that there is a structure on the posterior mitral valve leaflet. Or what is this? I want to discuss this with you, what this structure here is. Is it something that belongs to the PML, to the mitral valve? Is it something else? What do you think? The next peristernal view shows a little bit more clear the result of the Ross operation. And here you see the pulmonary valve in the position of the aortic valve through this replacement. Looks okay. Here you see the sutures with which the pulmonary valve is fixed in the aortic bulbus. A slight aortic regurgitation is still present. And this is a typical view. The right ventricle and the right atrium with the tricuspid valve and the pacemaker lead that is going into the right ventricle and the apex of the right ventricle. You get this view if you tilt the probe a little bit more superficially, and sometimes you get a very good look on the tricuspid valve. And if you tilt it a little bit more, we saw there's a little structure here that does not belong here. It's floating from the right atrium up over the tricuspid valve into the right ventricle. This does not belong here. I think you all will see that problem there. A little bit different angle and you see this structure a bit more clearly, and you now also will appreciate that this is not a small structure, this is a big one. In this view you can see this structure a little bit better, and it appears to be attached on the tricuspid valve here and floating in the right atrium. The next view, I performed a tissue Doppler imaging, and here you can see very good this structure glooming inside in the right atrium as it moves up and down in the right atrium. And I think it's an amazing picture where you see this structure with a totally different color while all the structures in the heart are moving. This is moving in a totally different direction, and it screams at us that it doesn't belong there. And here's another zoom picture, so a very big structure here. Probably on the tricuspid valve on this view, but not sure at all where it originates from. So the apical 4-chamber view, or already maybe 5-chamber view. Pump function looks okay, right ventricle is a little bit dilated. We see the pacemaker leads here and this structure on the PML again. Now the real 5-chamber view with a replaced aortic valve again, Ross operation and the sutures. The aortic valve velocity is okay with 1.58 meters per second. And here you see this mild aortic regurgitation. I put a Doppler on it, and you can see the pressure half time. The pressure half time is from 150 milliseconds, 509, 485, somewhat about mild to moderate aortic regurgitation. I would say it's a mild one if you have a look at the pressure half times. This is a zoomed image or a zoomed loop of the right atrium tricuspid valve and the right ventricle with a ventricular lead going into the right apex. And here you see the structure again. In this image or this loop, it seems to be attached on the ventricular lead in the segment of the right atrium. And if you measure this structure, it comes to 2.3 centimeters, 23 millimeters. So it's a quite big attachment here, quite big structure we have. In this loop we see the tricuspid regurgitation jet. We very often, you all know this, have these jets over tricuspid valves where leads are going through from the right atrium over the tricuspid valve into the right ventricle. There always is a little jet, but if you put a continuous wave Doppler in the jet of the tricuspid regurgitation, then you see that we have a elevated velocity over the tricuspid valve of 3.32 meters per second, and afterwards, sorry about the bad quality here and the bad reading, it's a maximum pressure gradient over the tricuspid valve of about 44 or 45 millimeters mercury. So it's an elevated systolic pulmonary artery pressure, and that is congruent of the findings we had with the elevated RV pressure, the increased RV diameter because of the pulmonary embolism. My question to you would now be, can you already tell what it is? Is it a thrombus or is it a vegetation? Can we be already sure about one of this or these two diagnoses? Well, let's have a closer look. In this view, you can see this structure very good, and we have the impression that it is attached not on the tricuspid valve, because the tricuspid valve looks very smooth here, normally not altered, but in this view we have the impression, or I had the impression, that the structure is attached on the lead, on the ventricular lead going from the right atrium over the tricuspid valve into the RV apex, and it is attached here. Very much movement of the structure floating in the right atrium and over the tricuspid valve into a part of the right ventricle. Very much movement. And this is the tricuspid regurgitation jet. Here a zoomed view, and I think now it's becoming very clear that our impression is right, that it is coming from the lead, the ventricular lead, and here it is attached. Again, very much movement of this structure here, very dangerous to get detached, loosened, and then getting into the RVRT and causing another pulmonary embolism. Another view with another degree, and also here we can see that it is attached on the lead and not has to do anything with the tricuspid valve. Again, a view on the Ross operation results, the originally pulmonary valve now under aortic valve position. The tissue Doppler imaging is not that spectacular as it was from the TTE, but also here you can see this structure floating with a different color than the surrounding tissue of the heart. So, what is it? What do you think? Is it a thrombus? Is it a vegetation? Or is it something completely different, something else? So, make a choice. Well, given the symptoms, the lab results and so on, we decided to go for vegetation. Bacterial vegetation on the lead, a lead infection. The body temperature was 38.8. The inflammation enzymes were high, and that led us to the conclusion that we might have dealt here with a bacterial infection, bacterial vegetation on the lead. And the pulmonary embolism is very good and conclusive with this diagnosis, because you saw how much movement on this vegetation was and how loosened it was, a little bit attachment there on the lead. So it's very good imaginable that some part of this vegetation already got loosened and went into the pulmonary artery and caused the pulmonary embolism of the left lower lobe. That is what we thought has happened. And so the vegetation probably was bigger before some parts went into the pulmonary artery. How would it have proceeded now? Well, I show you what we did. We initiated empiric antibiosis because At that point, we made our clinical diagnosis, but we did not have any blood culture results, and we did not know if there is a bloodstream infection to that point. But because it was a very big structure there, already happened embolism, we decided to go for vancomycin and gentamicin. We thought about rifamycin as well, and I would like you to comment in the comment section below if you would have chosen the same antibiotic regime or if you would have gone for another antibiotic therapy here. The anticoagulation was already established because in the emergency department and the chest x-ray we got the diagnosis of the pulmonary embolism in the left lower lobe, and because it was not clear what the origin was it a thrombus or was it a vegetation, the colleagues in the emergency department already established anticoagulation of the patient, and I think that was absolutely understandable and okay. Because at that state of a diagnosis in the emergency department, everything was possible at that state, and we also continued with the anticoagulation because we could not confirm our suspicion of a bacterial vegetation at this point. We offered the patient to a heart surgery department, but they declined the patient because they said this is a case for an interventionalist. The patient should get the leads removed via the venous cava superior and minimally invasive without another open heart surgery, despite the fact that the vegetation was 23 millimeters big. Finally, we admitted the patient to an interventional cardiology department with a very experienced staff of extracting ventricular or pacemaker leads, and with the presence of a heart surgery team in backup. In the meanwhile, the info came that the blood cultures were positive and we had a Staphylococcus aureus, so a very aggressive bacterium, and luckily the bacteria was sensitive to our established antibiotics. It was no bacterium with a higher state of resistance, no MRSA, but a normal MSSA. So, what was done then by the colleagues? Heart team's decision was after all to extract the leads via open cardiac surgery because of the danger or the risk that if you just pull the leads out over the vena cava superior and the vena subclavia, there's a very high risk of getting rid or lose the structure on the leads, and even if a small part of this structure is going loose and into the pulmonary arteries, it would cause another maybe devastating pulmonary embolism for the patient. And that is the reason why they followed our first suggestion to extract these leads by open cardiac surgery. So the patient got another thoracotomy, and the pacemaker pocket was opened, the leads were disconnected, and the tips were carefully extracted from the myocardium. But they couldn't be pulled out. Somewhere they were attached on the tissue of the vessel, and if you pulled on the leads on the top, then they did not come out. So after all, it was a joint venture of the heart surgeons and the interventional cardiologists, and finally the leads could be extracted via a special extraction sheath without getting loose or rid from a part of the structure and causing another pulmonary embolism. So everything went fine for the patient. What was the final result? Well, another sternal cerclages, another thoracotomy. The pacemaker has been over here, now is in a place of the pacemaker pocket over here, and you see two new pacemaker leads, and you see not the normal leads you usually would suspect after a pacemaker implantation, but this time the cardiac surgeons put the leads directly on the epicardium, epicardial leads on the atrium, and on the next slide you see a little bit better also the attached epicardial ventricular leads. So the patient had a new pacemaker with new epicardial leads now, and this from the lateral, the epicardial leads on the right atrium and the right ventricle, the epicardial ventricular leads. Well, thank you for your attention. I hope you enjoyed and liked the video and the clinical case. If you have some points you would have done something different in this patient, or the management of the patient, just tell us, leave a comment in the comment section below. I want to close this presentation with this amazing picture of the tissue Doppler imaging of the TTE, where one can see this structure so clearly because it's glooming towards us and shows us that this structure definitely does not belong to the normal structures of the heart. But wait, there's more. Because we had so many pathological findings while we performed the transthoracal echo and the transesophageal echo, we made two videos out of this one case. And there are some more secondary pathological findings that we have in this patient that it would have exceeded the duration of one video. And that will be the Why is the Patient Coughing Part 2 video we will upload in a couple of weeks, and we hope you will like this as well. So that's it for now. Yours Dr. Helge Alexi. Bye bye.